Then it will be an honor to follow up to the next talk. So we have got a pretty good talk from the University of Regensburg, and the authors will talk about contrast and ultrasound in the breast. So Isabella and Michael, I would like to welcome you.
Many thanks.
Thank you. Good evening, ladies and gentlemen. Today we are going to talk about contrast-enhanced ultrasound in breast imaging. We will start with general information, then a bit more specifically about breast imaging with the prerequisites, and followed by imaging examples and a conclusion in the end. In Germany and worldwide, there's a growing number of indications for contrast-enhanced ultrasound. The EFSUMB updated their guidelines for hepatic applications in 2020. But for the non-hepatic applications, the guidelines of 2017 are still in use. So what do the guidelines say about breast imaging? Well, unfortunately, it is not yet recommended for clinical use, but it's stated that it's an active field of research. Neither it is recommended for the clinical use for the identification of lymph nodes. However, ever since 2017, there are a lot of promising studies that might have an influence on the next update of the guidelines. So what do the studies describe the applications for? First of all, the characterization of benign and malignant breast lesions, the evaluation of tumor response after and during neoadjuvant chemotherapy, the differentiation between post-operative scars and recurrence, and of course, the evaluation of lymph nodes. But before we go to the imaging examples, I will just briefly mention the prerequisites. As Professor Klevert said before, we need the written informed consent. We need a high-frequency linear transducer, and we need intravenous ultrasound contrast media. We use up to 5 milliliters of Sonovue. The problem with the first generation contrast media was that it was not stable enough towards the high frequencies. And even with the second generation contrast media, even it's far more stable now, we need a higher dose of contrast media because the bubbles are destroyed by the higher frequencies. We need a low mechanical index, as for all contrast-enhanced ultrasound examinations, in order not to destroy the bubbles. And we need prerequisites that are usually stored in the high-end ultrasound machines, meaning tissue harmonic imaging, pulse inversion harmonic imaging, contrast harmonic imaging, and above all, we need experience, because we can only see and judge correctly what we know. Breast imaging is usually still performed by mammography. It's fast, it's widely spread, and it has a high sensitivity. However, in dense breast tissue, some lesions may still remain unclear or may even be hidden. So ultrasound is usually the next step in the diagnostic workup. In younger women with dense breast tissue, it might even be the first step of the diagnosis. There's a growing number of indications for MRI, but it's still pretty much restricted to some pre-selected indications like post-operative setting or high-risk setting in familial breast cancer. And of course, there's contrast-enhanced ultrasound, which we're going to talk about today. So for the characterization of breast lesions, what can we see? Here, hypervascularization is the keyword, because due to the angiogenesis, the vascularization of malignant lesions is far more prominent than in benign masses. And the enhancement is more peripheral with centripetal filling, whereas benign lesions show a more homogeneous enhancement. And this is also caused by the angiogenesis of the malignant lesions. We see disordered and distorted vessels, but we have to keep in mind that contrast-enhanced ultrasound can only visualize lesions that are also seen on conventional ultrasound, meaning we always have to focus on one lesion at a time with one bolus injection, whereas, for example, in MRI, we can just go through the images, read the images again and again, and focus on one lesion at a time.
What was the beginning about our research together with Professor Klevert?
First time you use a multi-frequency high-resolution transducer and you have to optimize the B mode. You could find a decision in combination with tissue harmonic imaging. Second, you could optimize the images using gross beam and speckle reduction technology. You reduce a mechanical index, and then you have a combination after bolus application of contrast agent in combination with high-resolution power Doppler to find the neo-vascularization of malignant breast tumors. Look at this. First results were that you have an excellent view over the tumor neo-vascularization, also in small lesions, the size up to 10 millimeters, using tissue harmonic imaging, contrast-enhanced power Doppler, and high-resolution linear transducers. Second question is, what about detection of small tumors also in breast tissue? Mammography is not enough for this. Look at this. In this case, you could find a malignant tumor not visible in the dense tissue on the right side, but using high-resolution contrast-enhanced ultrasound, you could find not only the tumor, you have a decision about the tumor size and neovascularization at the margin of the tumor. Next step, characterization of small lesions. From B mode alone, also from the elastography, it is often so difficult to find a final decision between benign or malignant lesion at maximum in size 10 millimeters. If you use high resolution contrast enhanced ultrasound, then you could find a decision, could we see an early and irregular hyperenhancement or not? Could we find an early washout or not? And you could find a decision also about the dynamic microvascularization using time intensity curve analysis. It is often integrated in your high resolution ultrasound machine. Typical for malignant tumors is a wash in and wash out kinetic. For benign lesion, typical is a continuously contrast enhancement. What we have to decide before we have to perform biopsies, we optimize the B mode. We could use a positional elastography for evaluation the stiffness of the tumor. You could use the contrast enhanced power Doppler for the neovascularization, but you need high resolution contrast enhanced ultrasound for clear decision which part of the tumor has necrosis or not necrosis and what are the real margins of the tumor. You have to perform biopsies at this part where you have the clear, irregular neovascularization in cases of malignant tumors. It is also so important if you have to find a final decision about the tumor size of breast tumors to use high resolution contrast enhanced ultrasound. Only using the B mode, the tumor also in this case seems to be smaller. If you use high resolution contrast enhanced ultrasound, you see the neovascularization at the margins of the tumor and you could find that the tumor is bigger in size. This is so important if you have to look for a follow-up after chemotherapies. Last not least, why it is so important to know about the high resolution contrast enhanced ultrasound, also in cases if you perform high resolution MRI. MRI is often difficult to find a decision about cyst, complicated cyst, benign tumor and a positional small malignant tumors if you have very dense tissue and you have an influence by vascularization of the dense breast tissue. So also in this case, not final decision using a positional mammography, but now look at this, the same case. Now you have a clear visualization from parametric imaging of high resolution contrast enhanced ultrasound that the tumor is up to 5 centimeters. And normally, look at this, the size from B mode was at maximum up to 3 centimeters. Now about this is so important that you have a view about the neo-vascularization of the tumors, and you could use a parametric imaging as a first step for artificial intelligence to look for the small tumors at the margin of malignant breast tumors. What about the combination with elastography and high-resolution contrast-enhanced ultrasound? From elastography, we have the criteria that you have an enhanced stiffness of the malignant tumors. But also from the elastography, it is not possible to have a final decision about the tumor size. You need the early arterial phase, and look at this here. You could see that the tumor is up to 6 centimeters in size. Means we need the real decision about the tumor size using high resolution contrast enhanced ultrasound. What is the future? You can use internal and external perfusion softwares. Look at this here. You have an example using the view box for different kind of perfusion parameters. Typical for malignant tumors is an early wash-in, means high peak enhancement, short time to peak, and short mean transit time. This is relevant for malignant tumors. In benign tumors, you have only a prolongated enhancement.
To sum it all up, for the characterization of breast lesions for malignant lesions, we see an early and strong enhancement. We see a washout with a more chaotic pattern. As we just saw it, we have an enlarged size when comparing the B mode with contrast-enhanced ultrasound images. Whereas in benign lesions, we can observe a slow increase of contrast uptake. It has a more neater visual pattern, and it has a ring-like enhancement. So once a tumor is diagnosed and the treatment begins, we need a reliable tool to evaluate the response toward neoadjuvant chemotherapy. So what can we see? We see a decrease in enhancement. In the tick analysis, we might see a significant decrease in wash-in, wash-out area on the curve, and an increase in rise time. And some tick parameters may even predict the response of breast cancer at a very early time when you cannot see the changes in size yet.
Look at this case. This is typical for malignant tumors. Tumors is at maximum 12 millimeters, but you could see from perfusion imaging the irregular hypervascularization in false colors as red and yellow. And in combination with time intensity curve analysis, you could find the early wash-in and high wash-in rate. You have a very, very short and high enhancement, but beginning also in the arterial form, the washout. Next, what happened if you decided for a chemotherapy in this case? Then the success must be visible after 10 days. Then you have to look for a devascularization of the tumor. Look at this in the false colors. You have less parts from red and yellow, and from the curve analysis, you have a prolongated enhancement with longer time to peak and reduced peak enhancement. What about the research for the future? We could use the optimized settings from human studies, also for animal studies for new chemotherapies. Look at this. This is a subcutaneous metastasis of breast cancer in a mouse model. And after 10 days, we have a very, very good success with complete devascularization. We could not see red and yellow colors in the false color-coded perfusion imaging. And from the curve, we have a prolonged less enhancement. Very good success.
So once the treatment stopped with surgery and chemotherapy, and the follow-up care begins, we need another reliable tool to differentiate between the post-operative scars and recurrence, which might be hard on conventional B-mode ultrasound or in mammography. To sum it up, recurrence mostly demonstrated a greater number of vessels and a strong enhancement, whereas a scar mostly showed no enhancement due to the missing neoangiogenesis.
Look at this case. Typical for a scar is that you have no enhancement in the center and you have less enhancement at the margin of the scar, same like the surrounding tissue. In false colors, You have not parts of red and yellow in the center of a scar, and in combination with time intensity curve analysis, you have a continuously enhancement, same like the surrounding tissue. You have no difference from time to peak and area under the curve. What about recurrence evaluation in combination with MRI? After successful chemotherapy, it should be no enhancement from the MRI, but in this case, you have a little enhancement at the margin, and you have the same resolution from high resolution contrast enhanced ultrasound. Typical for residual tumors is a nodular marginal enhancement.
So for the last application, the evaluation of lymph nodes, we can differentiate between the healthy lymph nodes that show a homogeneous enhancement, or the metastatic lymph nodes that might show an irregular enhancement with hypoperfusion or even a missing perfusion in some areas.
Look at this. This is the off-level use of contrast-enhanced ultrasound, but very successful. You perform a subcutaneous injection of contrast agent, and then you have a very early high enhancement of malignant lymph nodes. This is important if you decided for a lymph node biopsy, or if you decided for a neoadjuvant chemotherapy in cases of lymph node metastasis. If you find a decision between benign and malignant lymph node, in the normal case, you have to look in the case of lymph node metastasis, you have early enhancement from the margin to the center. And in the late phase, you have a very high enhancement of the lymph node metastasis. In benign lymph nodes, you have a beginning contrast at the center of the lymph node. Finally, what we think about the developments in the future of contrast-enhanced ultrasound. First step is, if you have older machines, you can use a combination with high-resolution transducers, reduction of the energy in combination with high-resolution power Doppler. I think important for the future is evaluation of CEUS perfusion in cases of malignant tumors and neoadjuvant chemotherapies. And look at this also together with Professor Clevers, we have first successful steps for new contrast agents like BR-RADS V for tumor-specific contrast agents.
So to sum it all up, as we said before, CEUS in breast imaging is an active field of research, and it improves the diagnostic specificity and efficacy compared to conventional ultrasound. And as we've seen before, the parametric imaging might improve the visibility of contrast-enhanced ultrasound. The recent studies suggest that there's a good agreement between ultrasound, contrast-enhanced ultrasound, and MRI when it comes to differentiation between benign and malignant lesions. Most importantly, contrast-enhanced ultrasound can downgrade BI-RADS V lesions and hence spare this mentally stressful situation of a biopsy for the patient. And also, in research, malignant lymph nodes and the sentinel lymph nodes can be identified. Thank you very much.
So I think that's a fantastic talk also from the University of Regensburg. I think there's a couple of questions in the chat function. So the question is interesting. Has COVID-19 and vaccination lead to any relative contraindication in regard to sono-vue?
I know that is a very special question. We have to talk which kind of COVID-19 infection we are talking about. You are very experienced about the lung ultrasound, also using contrast-enhanced agent. But this is not the aim of the question, I think. If you have a very severe COVID-19 infection, then it could be a problem that you know that is not without problem for the heart. And if you make an injection, you could complications about the pulmonary pressure. This is one of the contraindications. In the normal case, if you have a post-COVID situation, that you have no severe infections, then it is not a problem to use sono-vue as contrast agent. I think it is important also to reduce the dosage to apply at maximum 1 milliliter, but for the new technologies, it is enough also for characterization of lymph nodes and small breast tumors.
Okay, that's a good answer. I see there is no other question in the chat.